And so if you can build an efficiently and well-designed space, then you can drastically impact patient care in a positive way.
Welcome to Safe Space Made Simple, a practical podcast that guides clinical leaders and healthcare managers to create trust and support with their teams. I'm your host, Trace Hobson. Join me for weekly interviews, practical tools, and inspiring transformational stories of bringing people together in healthcare. Now, let's dive in. Hi, everybody. Welcome to Safe Space Made Simple. My name is Trace Hobson. I'm your host. And today we have a very special episode with Andrew Petrosoniak, who is an emergency physician and trauma leader, as well as the co-founder of Advanced Performance Healthcare Design, which is a company that consults organizations in their design as well as in simulation education. Andrew and I have an amazing conversation, and he brings incredible insights from his practice as a doctor, but also from the perspective of design and some of the things that we could be doing in healthcare in Canada to improve the way that we work, as well as to create a safe space. So without further ado, let's get right into the show. Well, listen, Andrew, thank you so much for being on the podcast. I've been really looking forward to being with you and to learning more about your work. So to start off with, I think it'd be great if you could just share a little bit about your work and how you got into the work you're doing and what you love about it.
Well, thanks for having me, Trace. It's a pleasure to be here. And thanks for, connecting. The work that you're doing is great. And I think we have a lot of shared interests. So I'm certainly happy to talk about, simulation, psychological safety, how teams work. All of those things sort of interest me and have been a key part of my work over the last 10 to 15 years. I'm super fortunate with the work that I get to do. I'm an emerge doc at St. Mike's Hospital in Toronto, where I also spend about a quarter to a third of my time specifically devoted to the care of critically injured patients, so doing trauma care. And that kind of makes up the bulk of my clinical work. And then I spend a fair amount of time as a clinician educator doing simulation activities, simulation work, and simulation is sort of the recreation of clinical events. And when I was doing my training in residency, I was fortunate enough to be recruited to Auckland in New Zealand, and I worked with an amazing physician, Chris Denny, who's a Canadian and moved to New Zealand, and he recruited me down there and taught me a lot about using simulation to not only use it for education purposes, and that's what we're most familiar with. That's what flight simulators, that's where what pilots use. We've adapted and adopted simulation to do more than that. We use it to test spaces, the way that you might crash test a car before it goes onto the road. We use simulation to design and test and revise processes, systems, clinical spaces. And so I learned a lot of that working with Chris, because we couldn't you can't really just cross your fingers and hope that working in a helicopter environment, which is where I was working, we were doing helicopter rescue work. You couldn't just, you had to be precise, and everything had to work properly. Yeah. And so we would use simulation to test that in advance. And so I brought that back, and I've been fortunate enough to be, I'm the lead for translational simulation, which is simulation that's not sort of educationally focused, but focused on testing processes and testing systems and helping design new clinical spaces at Unity Health in Toronto. And then more recently, this work has kind of expanded, and I now have I do some private industry consulting work with Advanced Performance, which is a company that I formed with a colleague of mine, Chris Hicks, who does similar work to me, and we put it together, and we work in a few different domains that has been really great. And we enjoy the work that it's really sort of quite interesting, the work that we get to do. We work with businesses in helping them take all of the skills that we know and have learned in high stakes decision making that we make in the trauma bay, and how can that be applied in the business domain. There's lots of high stakes decisions that are made every day, and there's a lot of parallels. The principles are the same. One may be, we're intubating a patient in one instance, and an executive is making a decision about, an acquisition in another instance, but the principles of those high stakes decisions are the same. The content is different. But so we work with companies as they're building capacity and building out their decision making. We also then use simulation to more in the healthcare domain. We use simulation to help design and build new clinical spaces. So
Nice.
just like you would, when you get into, you buy and build a new kitchen, you sort of will map it out and work with an architect, and it will work because you've kind of gone in there and you understand how it is that you make a meal.
Mm-hmm.
Unfortunately, in healthcare, we don't always do that. We sort of just have built spaces the way that we think they should be built. But so many times as clinicians, and I'm sure any of your listeners that are clinicians have been frustrated with the design of the clinical environment. And if you can get ahead of that and you can work with architects, work with designers, work with hospital administration, you can build great things by involving the end user early. And so that's one of the other areas that we work with. And then more recently, we've been working with some med tech companies doing simulations to help revise and improve their products. So that's kind of some of the consulting work that we've been fortunate enough to do. So I get to do a lot of different things in my week. Everything from taking care of patients to doing, sort of working with business executives to thinking about how we can educate our staff better around using simulation. So the work's varied. It keeps me on my toes, and I love all of it. I'm super fortunate to be doing the opportunities and be given the opportunities that I have.
Yeah, that sounds amazing. One of the things that I loved about reviewing your website was looking at the design implications of looking at spaces like you've described, and how I was a bit surprised, I guess, as a layperson. I mean, I've only been working in healthcare as a leadership consultant and and a support for psychological health and safety about the last 8 years or so. And so as I get more and more education on clinical spaces and what, a clinical practitioner is dealing with day to day, I'm constantly surprised. So I guess I shouldn't, wonder about that. But the fact that we don't test the spaces ahead of time, and looking at your website and seeing the graphs and some of the project work that you've done, I was like amazed by that. And I thought, wow, that is just so smart. And it really, we do use it in other ways. I remember back when I heard about and studied the McDonald brothers when they first started McDonald's. One of the brilliance of their systems was that they stood up above the workspace and looked at, what the flow was going to be. And so, I mean, that's a restaurant, like to your point about restaurants earlier. So what is it that a leader needs to hear, an executive needs to hear? Because I mean, I'd like to say, well, so we're doing simulation for everything before, right? Like I'd love to say that that's not the truth, right? We're not doing that. So what is the net return for doing simulation ahead of time projects like you're working on? And what would you tell an executive leader that's looking at that sort of bottom line implication of that?
I mean, it's a great question, and it's a question that we get asked all the time. And I love that you brought up the McDonald's phenomenon. I think the movie The Founder
Yeah,
is what maybe you're alluding to there. And
I am. Yeah.
they a great it's a great movie for those that are interested in watching it. And they do show exactly, they simulated the work in advance of the movement of, making a hamburger in an efficient way, and they didn't get it right the first time, and they
Right.
iterated it. But what was efficient in their process was that they tried, without actually building the physical environment, they taped it out on a tennis court. At least that's how they describe it in the movie, and then brought people in, the actual end users, the people that would be making the meal, and tested to see how it would feel, how it would work. And so it's such an efficient way of doing things. Rather, the way that we work in healthcare is we would have built the restaurant and then retrofit the work,
Mhm.
which is such a bizarre construct. And in tech, that's not sort of how things work. And in other environments where efficiency is paramount,
Hmm.
and to be honest, and perhaps there's some financial implications in a Canadian healthcare system where
Right.
where payers are different, but broadly across the world where there's private healthcare systems, public healthcare systems, all that, we all seem to work similarly. And unfortunately, we hope that the resilience of the clinicians will overcome the poor design of the spaces. And if I said to you, for instance, or if I said, we're going to bring a F1 team to change the tires in my driveway. And I said, let's see how fast it takes them. If we brought them right to the track, they could do that. They do it within 2 seconds on the track, right, during an F1 race. If you brought them to my driveway, I bet you they for sure would be faster than me. But I don't think it would be done in 2 seconds. And the question is why? It's the same people, it's the same skill set. But my driveway is not meant for tire changes. It's systematically hindering them in doing their work. So of
Hmm.
course they're going to be slower. And the same is in healthcare. When we think about design, we get far greater yields and returns on our investment if we simply design spaces to prop up a team rather
Right.
than to crush it. And unfortunately, we have taken an approach where people feel it is faster just to go build and worry about the consequences after.
Hmm.
So I'm reminded with this type of question, I'm reminded of the McLeamy curve, which is a concept that's well known to architects, but unfortunately hasn't really made its way into the healthcare space. And to describe that curve, it's effectively two lines. The first being a line that starts at the beginning of a project and is the ability to impact that project. And it's quite high at the early stages of a project. By making any change, you can drastically alter the beginning of a project. As the project progresses, the ability to impact changes in the project is harder because you've gotten closer to the finish line. In contrast, there's an opposite progressing curve that is the cost of any design changes. And so that ultimately increases cost over time. And so at the end of a project, it's very expensive to make a change and it's very difficult to make a change. Where at the beginning of a project, it's very easy to make a change and not so expensive. And this is what we try and use simulation for, is to push in the most efficient way possible, make changes early so that it has maximal impact with minimal cost. And that's what we do when we go and talk to executives and within hospital administration and leadership, and we say there's a few massive costs by waiting and not getting it right with the design. The first and most clear cost is the cost to the impact of patient care. If you have a poorly designed space, you simply cannot deliver the care that you need for that patient. Just like we talked about, analogous to the F1 pit crew who's trying to do tire change in my driveway. And so you simply can't if you have a poorly designed environment, you can't change the tires in an efficient way, just like you can't take care of a sick trauma patient in an efficient way. And so if you can build an efficiently and well-designed space, then you can drastically impact patient care in a positive way.
Mm.
The other thing is that things can happen faster. And so you can make decisions quickly using simulation. It's a very efficient way. By running an hour or 2 hour long simulation with a team, you can accelerate your decision making in a way that you simply can't by meeting around a boardroom. The other thing you do is you get to do that with greater certainty, because when you make the decision, you know whether it's going to work or not because you've literally tested it. It's like crash testing a car. Car companies do this every day. They don't roll out cars that don't perform well in a crash test because that isn't a financially or a physically safe thing for consumers. And so we apply that same principle by using simulation. We call it immersive design, where we immerse the clinicians in the design process. And it's this process that we've found quite efficient. There's a ton of upside for the users, because they are then invested in the process themselves. They get to actually impact the design of the space, and it's a net win for everybody involved. We bring in architects to watch that process happen. They're involved. It's very frustrating to be an architect when you're trying to design a hospital, because you're constantly trying to connect with busy nurses, busy doctors, busy respiratory therapists who just don't have the time to do so, to give you answers to your questions.
Hmm.
So if they can watch them work, it's a much better use of everyone's time, and then they can design it exactly the way that the clinicians work.
That's amazing. So, what have you learned in specifics for some of the case studies or experiences you've had with this? I mean, I'm sure it would be nice to get into a building before it's ever designed and do it. I'm guessing there may be some retrofits that you've also worked on as well. And so, what kinds of things are you learning in terms of the level of patient care that goes up or down, as well as some of the team dynamics that are happening with involving the stakeholders on the front end like that?
Yeah, I mean, we've learned a lot over the last few years in running these. One, it's simply an amazing way to bring a team together and to share ideas, and be part of something, and feel invested in the design of a new space, or the design of a new system, or giving feedback on an existing system or space to make future changes. And so just bring that team together, running simulations with them, recreations of clinical events is what we're talking about here, is really such a powerful way to enhance a team dynamic, because then they get to debrief together, they get to think together. It's a dedicated time where we just don't have that in our usual clinical days, where we have time to sort of think about exactly how we work. In
Hmm.
healthcare, we pride ourselves on overcoming the encumbrances that are built into poorly designed spaces and systems and processes.
Right.
It's almost like a badge of honor for us. It's like, I overcame a poorly designed space and I was still able to save someone's life. That's something that happens, I think, every day around the world.
Wow. So let's pivot into your practice as a emergency doc. One of the things that I was looking forward to speaking with you about is just how does somebody who is working in what, from the outside looking in is chaos in the emergency room create a safe space for themselves and others in the middle of all of that activity? What have you learned as an emergency physician around that?
Oh, I mean, it's such a great question, and I think it's one that we continue to try and improve upon. I think the idea that, we can generate and create established psychological safety, which I think is kind of what you're referring to, is I think it's never. I don't know that it's a binary thing where it's achieved or not achieved. I think it's an ongoing, uh, I don't know if struggle is the right word, but it's an ongoing task where we continually try and be better every day with creating a psychologically safe environment. And what I mean by that is a place where people feel like they can speak up without sort of fear of any retribution, where they can take risks, and that all leads to better team performance. And I think we've tried different things over the years. I mean, it is clear that a psychologically safe space, psychological safety is one of, maybe if not the most important element in a high performing team like we have in the emergency department. And that was some of the work, in the outside of healthcare. That's the work that Google did with the Project Aristotle, that they kind of came up with the idea that that is really such a high predictor of a well performing or high performing team.
Mhm.
And so we look for that, and we try and think about sort of key principles. And for us, some of those principles are, as a leader, to be able to show humility and embrace fallibility. I think is absolutely key. To be able to show that, hey, I may not get this right, but that we're going to try something, and I need feedback about how I may make a decision, and I think that's absolutely critical in helping a team, be psychologically safe, or safer
Mhm.
than they had been. And so I try not to think of it like, oh, we're either it's psychologically safe or not. I think it's a stepwise progression to better. And that's
Yeah,
what we try and embrace.
yeah, I really appreciate the way that you're putting that. To me, it's a practice as well of psychologically safe spaces or psychological health and safety. And I especially just am thinking about what you were sharing earlier, that when you're doing design work around simulation, the whole team is carving out time and creating that time to work together. And the net benefit of that, or the sort of the byproduct of that, is that there is psychologically safe spaces because we're taking the time to develop that. I'm curious what, if any, ingredients you've been able to create in a clinical setting that are similar, so that we're carving out time for that as well. What kinds of things are you doing with your team, or what ingredients could you put or bake into that cake, so to speak?
There's a couple of things that I think that we have tried and have found successful. And it relates, I think it's easiest to think about it in the context of a particular patient resuscitation, where, in contrast to just daily work that's happening, where we might see a patient, and then, as a physician, I'll see a patient, and then a nurse may be, doing IV access and that kind of thing, and will be caring for a patient kind of asynchronously over the course of their time in the ED. But I think where the psychological safety elements are most important are when we're all around a patient together doing a resuscitation, and where the stakes are high, and where we really can't afford, where a mistake, or a misstep really has dire consequences, a matter of life and death. And so one of the things that we found super helpful in helping create a space where I think it's more psychologically safe than not is pre-briefing. And so we will
Mhm.
often get a heads up about a patient coming in, or a situation. We don't always know. We have a fair amount of uncertainty, but we will get a sense like a patient is coming in cardiac arrest, and we might have 2 minutes. And the act of bringing a team together, introducing everybody, because we often work in an ad hoc team where we don't know. In my emergency department, we have to know everybody, or almost everybody, but there are residents that we don't know, or medical students, or certain nurses particularly with the high turnover that's been more prominent in the last few years. So we may not know everybody's name. So we'll introduce each other, and we'll assign roles. And just knowing what you need to do, and assigning roles, and knowing a person's name is a huge way of being able to feel like you're part of a team, and being able to perform at a better level. In contrast, just saying something like, "Hey, you over there," it's much easier to say, "Hey, Trace, can you help me with something?" We do that, and we pre-brief with a set of, what do we know, what are our priorities, and what are our initial first steps. And so that allows people to have a sense of what needs to happen in the first few minutes, and we can kind of script that out, and that allows people to feel comfortable. It also allows us to be held to account as a leader. So,
Mhm.
for instance, if I say, okay, I'm going to predict that we're going to need to intubate this patient, shortly upon their arrival in the emergency department. Okay, great. That's the plan. And if we don't, let's say I get task focused on something else, or I forget that, I've now allowed my team, I hope, to be able to speak up and say, "Hey, Andrew, you said we were going to intubate this patient. We haven't. Can you tell me why?" And now, because I've already said it, I've already laid that out in the groundwork in the pre-brief. I'm not going to take offense to that. That's true. They're making an accurate statement. They're making an observation, and they're holding me to account. Now, I
Hmm.
may decide, oh, there's a clinical reason why we are not, or, oh, wow, in fact, I missed that. I just totally forgot that that was going to be the priority. And we've had this happen where when I'm working in the trauma bay, our goal is often for certain patients to get to the CT scanner quite quickly, in contrast to going to the operating room. And one of our clericals, I still remember this, she came up to me. And so she's a clerical staff, and her job would be coordinating basically our exit from the trauma bay to get the patient to the CT scanner. Their jobs would involve managing all the about 100 phone calls that happen in the course of about 5 minutes, getting other consultants into the trauma bay as needed. And she said to me, because the pre-brief said our goal will be to get to the CT scanner in the next 15 minutes. And let's imagine it's 2 p.m. So by 2:15, we're going to be leaving.
Hmm.
And it was about 2:20, and she said, she kind of spoke up. And to me, I knew we had a psychologically safe space where she felt it was appropriate for her, as even as a non-clinical person, to say, Andrew, I just want to let you know. And she said this in front of the whole team. We're now at 2:20 p.m. You had said you wanted to be out of here at 2:15. Is there something that's changed?
Yeah,
And
that's
I didn't
great.
take any offense to that. In fact, it was like, oh, finally, I'm being held to account to what I said. Now, I then had an opportunity to say, well, actually, we just needed a few more minutes, but you're right. We actually do need to go. Thank you for that. And so that
Yeah.
pre-briefing is really key. And then the debriefing is also really key. And we'll come back and speak about, what exactly happened. And and then we also use some kind of effective language where we try and empower people to be able to speak up. And one of the things that I love to say as a leader, in particularly as we're I might summarize a particular situation for, we have a patient in cardiac arrest. They've been here for 15 minutes. Here's what we've done. Here are our next priorities. And then I'll say to the team, what am I missing? And
Mm.
that simple 4 words is I've found very powerful. I don't say, I'm very deliberate with what I said, and I've learned this from my colleague Chris Hicks, who's a emergency physician and trauma doc like I am, and a mentor of mine. And I don't say what else needs to happen, because that's sort of generic and not specific. I want to identify that me as the leader could be missing something, and that I'm fallible. And
Mm.
it's that, what am I missing, has really allowed for the team then to speak up and say, either you're not missing anything, or, hey, you are missing. Here's what I've thought about. And it
Mhm.
and it exposes my own vulnerabilities.
Wow, this is really powerful to hear you sharing like this. That's a very powerful coaching question that you added at the end there. It also it's really interesting the way you're describing it, because I've observed of different teams that are in high pressure, high stress situations that there's a sense of timelessness, or there's a slowing down that happens under that emergency situation. And you're giving me very practical, concrete reasons as to why that might be, with that pre-briefing that's happening in that roundtable introduction that's going on there, as well as the debriefing after the fact too. And as I'm thinking about this, and just wondering about that pre-brief that happens, that pre-brief provides a little bit of an on-ramp to merge into the freeway of uncertainty that's happening in the emergence of what's going on in that situation. And I love the way that you create that relational connection, and also clear understanding of what everybody's roles and responsibilities are. And then you're in this fluid situation where now it's safe to be able to talk about changes. Everybody's on the same team, shoulder to shoulder, working together. And then to debrief it is really a relational exercise too, I think, where you've kind of got a sense of, what did we learn, and what am I missing, is just a great coaching question to be able to ask in that situation. Now I want to pivot a little bit again, and I'm just curious, one of the things that I've observed over the last 8 years in working in healthcare is that there's this big gaps that are, between the point of care. There's these big gaps that occur between the point of care bedside, then you go to clinical leadership, whether that's nurse education or patient care coordination. And there's a gap oftentimes between those two stakeholders. And then there's another gap between the clinical leadership team and the manager or leader who's leading that clinical area. And then there's even another gap between them and their director, and so on. You can go ED and then on from there. But just in looking at that, those gaps between the point of care and clinical leaders, and then clinical leaders and their leader, and especially the leader at that point and the point of care. What do we need to do from your perspective to close those gaps and develop relationship?
Well, yeah, I mean, I think that is certainly a component that or an observation that I think is accurate, that there is, you know, differences between what's happening on the ground, perspective from different leadership roles in a healthcare institution and a hospital. We find the idea of I think what is missing is the idea of understanding what's happening on the ground level, and
Mm-hmm.
that sense that those who are making decisions truly understand the work of the frontline clinicians. And I think that that's something that, I think all of us feel who are on the front lines, that it's not always truly understood, the difficulties, even if it is said that the leadership will understand those difficulties. Uh, and I think it's trying to bridge that understanding, and that the those who are working under difficult environments, taking care of patients on the front lines on a regular basis, how can you share the challenges in an authentic way? That
Mm-hmm.
is one of the things that we find helpful with. We use design thinking techniques where we put people in the roles that they're doing. We trying to empathize with the end user. We try to understand exactly what's happening, and then we allow healthcare leaders to observe what that is, so that
Mm-hmm.
they can make decisions, I think, with a greater understanding and from the lens of the frontline clinicians. That's one of the reasons why we use simulation as well,
Yeah.
is
Yeah.
that when we're building hospitals or building new systems or processes, there may be a decision that's made around a boardroom table. But if we can translate that and remove the boardroom table and put a simulation in that space, and then allow those leaders to watch and observe and or participate, it does allow for a better conversation, because then there's a feeling by all involved that that they're closer to understanding what the challenges are. I can
Yeah.
tell you what the challenges are that I experience on my daily basis, but if you see it and you see my frustration, it's far easier for you as a leader in healthcare to be able to empathize with me, and then to say, okay, here's how we can actually impact. Because there are many great leaders in healthcare
Mm-hmm.
who can have substantial impact, but sometimes they just simply don't understand. And so it's our job, and the job, a continuous job, I think, uh, throughout the sort of healthcare space, is both as clinicians and those who are making, in a more leadership role, to kind of bridge that gap. And that's what we're
Mm-hmm.
looking for.
Yeah, I really appreciate what you're sharing right now, because I think you've nailed it. The observation that I've made over the years as well is that oftentimes executive leaders are talking about the things that are the same things that might be expressed at that point of care, but they don't understand it viscerally. And so I really appreciate how you're connecting that to the idea of simulation and bringing them into that simulation so that they could actually feel the embodiment of that concern or that challenge in a different way so that they're informed on their decisions. It also makes me curious about what your thoughts are on using simulation in more sort of interpersonal, intra-professional, and multidisciplinary teams in terms of relationship building or even communications and being able to have a difficult conversation or being able to navigate setting boundaries for yourself in a with a boss or with a leader. How might we use simulation to do those scenarios as well and kind of step out of the clinical for a moment and just look at that? I know you mentioned that you're doing some stuff in the in industry. So what could we do in healthcare to create that kind of environment where we're simulating real world scenarios that are maybe interpersonal and a little crunchy at times?
Yeah, I mean, the work that Eve Purdy and Vic Brazil are doing in Australia focuses a lot on that. A lot of the work that I focus on is around the design. How do we use simulation to recreate designs and make them better? The work that they do is often around building and improving culture.
Hmm.
And it's amazing sort of work that they've focused on. And I think using simulation, recreating particular events allows us this idea that we can practice these communication skills. The notion that we just are good at communicating seems somewhat flawed to me. I mean, it is a challenging thing, and when we run simulations, we are often doing them in a multidisciplinary setting. So it allows us to practice these things. People are not inherently good communicators. Those who are best at communicating are those who practice. If you listen to any amazing orator, someone on stage who, whether they're a stand-up comedian or whether they're a professional speaker, every single one of them, if you ask them, practices. They all rehearse. We just expect as audience that they're just good at this, what they do. But communication is a skill that can be improved upon. And so any opportunities, effectively simulation and basically, which is just a recreation of an event, recreation of an opportunity, these skills can be practiced. And so, the idea that you can create training models that include practicing communication is something that, I think is really quite important and certainly can be taught through that rather than reading it in a textbook.
Mhm. Mhm. Well, thank you for that. I think that that's true as well. And so, just wanting to look at the being respectful of your time and coming to a close here, Andrew, how can people get in touch with you to learn more about your work and about what you're doing in the world?
Yeah, I mean, they can certainly find me on Twitter at my Twitter handle's at Petrosoniak, and they can also check out our website, advancedperformance.ca. They can connect with me there. And we're always looking for interesting ideas and talking to interesting people that think differently, because I think that's what really makes the work that we do fascinating for us. Is we get to meet interesting people all the time who are interested in challenging the status quo, interesting to think about and think outside the box. And I think that's what makes life interesting, is thinking a bit differently and continually challenging the way that we've traditionally done stuff may not always be the best. It's the default, which is often the easiest. But I think that there's so many opportunities out there. So I'm certainly happy to talk to anybody about you know any ideas that relate to design and processes and systems and decision making. All of these things are sort of why I get up in the morning.
Yeah, amazing. Thank you so much, Andrew. And we'll include all of those in the show notes for those of you that want to connect with Andrew and reach out. And so look in the show notes to be able to reach out and chat with Andrew. Andrew, thank you so much for your time. And I know that you're a busy man, so I really appreciate you coming on the show and sharing your wisdom and what you've learned. Thanks so much.
Well, thanks for having me. It's a pleasure, and I love the conversation.
That's great. Until the next time. Thank you so much for getting to the end of the show. I really appreciate your time and your effort. And I trust that this served you. This conversation helps you now to go back into your practice as a clinical leader, a manager, or an educator and start to think about things a little bit differently. If you'd like to get a hold of Andrew, you can click the links in the show notes. That will help you to get in touch with him, or you can reach out on LinkedIn. Thank you again for listening and or watching on the YouTube channel. And until the next time that we see each other, remember to be a safe space. Thank you again for getting to the end of this podcast. And if you enjoyed this and you found that there was value in it for you, my invitation is for you to subscribe for future episodes that come out weekly on Tuesdays. Thank you again, and I'm looking forward to being with you next time. Now remember to be a safe space.